episode of Stories of Care, the podcast that explores the intersection between healthcare equity and infection prevention and control. Today, I'm really excited to have a guest with us, Dr. Gonzalo Bearman, to discuss another part of burnout, a big part of what we all face oftentimes throughout this career. So thank you so much for being with us, Dr. Bearman.
Great. Thank you so much for the introduction. It's an honor to be here with you.
I am so curious. You have had a very long, storied career. Tell us how you have gotten to where you are today. What is your story?
Well, I mean, my story is a little convoluted at times, but then it's also not that unconventional. I'm from Argentina. I was raised in Argentina in the United States. And I did obviously junior high school and high school in the United States and went to medical school. Although I am the fifth doctor in the family, I want to be very clear. Did not blaze a trail here. Not like I'm the fifth doctor in the family. When I went into medicine, I just kind of made the decision to do that when I was at college at Colgate University, because it seemed like that's what others were doing in the family. And it seemed like a decent enough job. I knew nothing about public health, virtually nothing about infectious diseases. Didn't know what a master in public health was, et cetera, et cetera. I just went to college and I played on the college soccer team. That's pretty much it. And I tell you that because it wasn't until I got to medical school. Then when I was sitting in the infectious diseases med microbiology lectures, I think it was second year back then, 1994, I was like coming out of my seat because the people that were presenting the lectures seemed like really cool middle-aged doctors who had a lot of energy, and they were showing great cases and talking about their travels and the cool things they saw. One thing led to another, and I was able to approach them, and they were very welcoming, gave me a quick introduction to what it's like to be an infectious disease doctor, talked about public health and those kind of things. And that kind of led me down the path of infectious disease, public health, and ultimately healthcare epidemiology. When I was doing my training at Cornell University in infectious disease, it became quite obvious to me and to the mentees I had that I probably wasn't going to be a clinical researcher, and that epidemiology would probably be best for me. So go speak with Dr. Lewis Drusen and that group, and that got me launched.
I can relate to that. I very much, I dabbled and benched to try to figure it out, like we all did, of course, in infectious disease at one point or another, and realized pipetting was not my life goal.
Absolutely. And I do have to say, a couple huge influences in my career, definitely early on, were Richard Wenzel and Michael Edman. So I came from Cornell to VCU almost 21 years ago, and Richard Wenzel was the chief of medicine at that time, and Mike Edman was the healthcare epidemiologist, and they provided invaluable mentorship, friendship, and just guidance.
So were you in healthcare epi before you got to VCU, or was it really that mentorship at VCU that made you say, hey, this is the world I really want to be in specifically?
Well, I did my third year at Cornell University as a fellow, and they sent me to Columbia to get the Master in Public Health degree. And I spent my third year focused on healthcare epidemiology. So that's where I learned kind of the nuts and bolts. But it really was under the supervision and mentorship of Mike Edman in healthcare epidemiology, and also Richard Wenzel at large.
Okay, so it's really kind of what ended up carving your career ultimately.
Correct. And I've been at VCU ever since. I never thought I'd stay that long, but 21 years later, here I am still.
So tell us a little bit about your work in leadership at VCU. So you are in the healthcare epi department initially, then healthcare epi focused. Now you're the chair of the overall department.
Yeah.
But tell me what has your focus been while you've been in leadership there?
So I really had two leadership hats for a long time. I was doing both the division chair, and I'm now starting my 11th year as division chair of here at VCU of infectious disease. And then I was in healthcare epidemiology, leading there for about 8-9 years also. So there are two different experiences, but there's a lot of similarities, right? And with leadership, there are a lot of lessons learned, mistakes made, and also some many positive things too. But I think what I've learned over the years is to really understand leadership from a perspective that goes beyond that of the leader. It's a combination of the leaders, the individuals, and the teams. And that's what I've really been meditating on recently, like what makes teams thrive compared to what makes other teams not thrive, at least in our healthcare setting. And what can we do to make people define their values, their purpose, feel like they're important, keep them engaged. That's really important. And to mitigate burnout. Don't have the antidote to burnout. But what I've learned is there are things that can be done on the individual and team level by leaders of divisions or small departments or even larger departments to make that risk of burnout less intense.
You touched on so many things I want to ask you about there. First off, you've said you've been really meditating on the whole concept of what makes a team thrive, even before we get into the mitigation factors. What have you read? What have you thought? What have you discerned from that meditation?
Yeah, so I think one of the things that's important for a team, and I use a lot of sports analogies. And the only sport I know is soccer, and that's why I've written a paper on leadership and soccer enthusiast perspective, et cetera. So getting to that idea is, I think that we talk about teams, and let's just talk about a division of infectious disease, for example, one that's most close to me right now, is that how do we define that team? So do you find a team, is it just the faculty? Is it a team of faculty and a team of fellows and a team of staff and a team of nurses and a team of pharmacists, or is it one big team? And if you have one big team, do you have a clear team ethos or culture statement? Let me stop for a second. I try not to use the word culture statement because I think that too many institutions, myself included, have adopted that culture statement and it becomes so corporate that it means nothing. Like if you look at the culture statement of a health system, it is 50-pronged, and you have no understanding what it really means. So we actually did write a culture statement we call it an ethos statement here at VC. And it sets the tone for the team and the team rules. So the team ethos statement is pretty simple. It's the division of infectious diseases strives for excellence in all matters of work. Don't say research versus clinical versus education. Excellence in all matters of work, with a focus on our faculty, fellows, and staff. That covers everyone. Driven by the values of inclusivity, transparency, collaboration, and work-life integration. So those are the team rules. So everything we do has to fall under those team rules. Now, why is that important? Because later on, as you get to spend more time with team members, you realize that everyone has a different purpose, sometimes slightly different values, and different goals with their professional trajectories or jobs. So how do we allow them to be successful with those individual goals while still fulfilling the team need? And that's really important. That's why I use the analogy of like the soccer. I say football for soccer, but the football coach, there's 11 players on the field chosen by the manager or the coach to be out there, but they each have different roles, but they're all playing for the same game and the same purpose. You got to think of it that way.
So where did the mission statement come from? Was it a group effort? Who all was involved in creating this?
It was a group effort, and I will admit that I took the first stab at penning it, and then we got feedback, both in-person feedback at the faculty and staff meeting. We took down the notes, we wrote it again, we sent it out, gave a couple more days for feedback, re-edited it one more time, and then gave it another round for feedback, and we finally codified it. And it's one thing to have it, it's the other thing to try to make it visible and be a living, breathing document, so to speak. So we talk about it, but we also took a copy of that and we printed it, we properly framed it, we stuck it on every floor of our service, which is 2 floors, and in our clinic front and center in the doctor's room, and where the staff room there. So it's there for reference. Like, those are the team rules, everyone. Words to live, the words to live and die by, so to speak.
That's awesome. Did this all happen pre-pandemic? I feel like that's a big hallmark in the infectious disease world.
No, it actually happened post-pandemic.
Okay.
And I think what got me really meditating on that was some of the things I've seen and read and learned about the importance of team dynamics, right? There was a really cool paper that was published pre-pandemic, actually. Actually, it really wasn't a paper, it was a long newspaper article. And I think it was in the Sunday New York Times magazine, like in 2017 or something like that. So it's before the pandemic. And basically was a study on Project Aristotle, which was basically the name that was given to the Google corporations. They had I don't know if they hired a third party or they had some behavioral scientists look at 100 different teams across Google. And to define, of all those teams, those 100 teams in the Google, I guess, enterprise, what made the teams most successful? Now, maybe Google teams don't represent all other teams in the world, but it had an interesting conclusion. And it wasn't so much the why of the makeup of the team. So this is not a comment against diversity, et cetera, et cetera. But what they were saying is it really was the team dynamics that was most
Mhm.
important. And that meant that the manager had to have a dynamics of the team where it was accepted, encouraged to have open, honest discussions about all matters
Mhm.
of work and really to address the day-to-day annoyances. Because if you can't address the day-to-day annoyances, then that friction starts
Yeah.
to come in, and that causes division and strife. And to really watch out really for non-team players. Non-team
Mhm.
players are probably one of the biggest threats to a team dynamic. If you have 20 high functioning people and the 21st is high functioning but not a team player, then
Mhm.
that's going to cause a problem,
Mhm.
big problem.
So, first talking about the team dynamic,
Uh-huh.
in a place like medicine, what you're talking about is so hard because we have this ingrained hierarchy. But it sounds like that was a part of what you're trying to take on with trying to create this really safety dynamic where anybody can bring up an annoyance or a question as you mentioned. How did you handle that? Trying to really counter, I mean, what's been stuck in medicine for centuries, honestly.
I think it's just through a lot of dialogue and getting perspectives and feedbacks from others. And I think it's also having open discussions with your team. Like, team, we all want to feel comfortable talking about issues. Is that
Mhm.
correct? Does anyone not want to be able to talk about issues? And
Mhm.
people do. And we want to feel comfortable addressing each other. And we should be able to say, Gonzalo, I'm calling you out on that because I don't agree with that. That's fine.
Mhm.
As long as we're not no ad hominem attacks, no name calling. I think we can have important discussions that can lead to shared missions and shared truths and shared action items. And that's really critical. And remember, it doesn't have to be faculty to faculty, but the
Yep.
person answering the telephone at the front desk has
Yep.
pretty much the right to raise her concerns about any component of the project here. I do call it a project because it's never ending.
Yep. Yep. I mean, that's so critical. And I believe in that mantra so much,
Mhm.
but it's definitely a hard mantra to find home in the world of the hierarchy of medicine without creating some ripples. So I'm really glad to see you pushing that. But then it brings me to the other aspect that you mentioned, the non-team player. So as you're creating this new ethos, putting this out there, did you identify non-team players in your environment?
We've had non-team players here. Um, Obviously, will remain nameless. We're no
Hmm.
longer with us. So yeah, I think there's generally three possibilities for non-team players. One, that they,
Hmm.
with redirection feedback, they have insight and they realize they do want to be part of the team and they adjust. That's option number.
Hmm.
Option number two, they're such non-team players that there are all sorts of egregious behaviors that they're essentially terminated, which is uncommon. And then option number three is the one where they see that it may not be a great fit for them. It's not anything explicit. It's not as if they're being reprimanded, et cetera, but they essentially seek happiness elsewhere. And that's okay. And at first, we have a very low turnover rate here at VCUID, which we're very proud of, and it's lower than the institutional standard. But you're going to have some changes for whatever reason. Many of them are great reasons because maybe one of the spouses has got a great new job and opportunity and they need to relocate, or they found a new position, a career opportunity that we could offer them that, and they need to relocate. We celebrate that. But as a leader, I think it's important to not only be aware of potential non-team players, but also understand that eventually you might have to have a lineup change. And that happens in all great teams or, you know, productions or
Hmm.
whatever, sports teams, et cetera. There's a lineup change. Bands, rock bands, they have lineup changes. It just happens.
And so, what are some of the tactics that you have found successful in helping a non-team player become a team player if that's the route that it goes?
Yeah, so I think that that's a great question. So there's really multiple approaches.
Mhm.
Number one is those individuals have to be aware of the team ethos statement. I recently hired some new doctors and they all come here and they're very aware of the philosophy behind the group, leadership, et cetera, et cetera. And in the event that one of them says, oh, I'm too busy to do that, et cetera, I've generally learned that a gentle phone call or gentle discussion saying,
Mhm.
you're doing great. We love everything you've done here. You've been with us 6 months, a year and a half. You're really contributing. And I know you're a team player. Therefore, I need you to do this not only for the team, but although you don't think it's great for you right now, it does add or build towards your promotion and tenure, for example. It gives you a new experience that maybe you didn't have. If it's too painful, come back and chat with me about it. But it's something I'm asking of you that others have done, or something that I've done myself over the years. But that redirection I find is very helpful. In other situations, you have to have more explicit discussions, like complaints have been made about A, B, and C. I want you to meditate on that. I know you're a team player. We want you to succeed. It's in my interest to have you succeed. It's in your interest to succeed. We both have the same goal. So let me know how I can help so you can be not only great as an individual doctor, researcher, whatever you're doing, but you can also be a great team player for VC or infectious disease. Most people are pretty responsive to that.
That's great. I think one of the things that often is forgotten is clear communication in all different genres, not just in medicine, in all different genres. And so having that pathway of clear communication can really make the difference.
Right. And that communication starts early on. If you wait till they're here 6 months, 9 months before having really formal discussions with these individuals, you're kind of waiting too long. You should have it the first month after 2 weeks of moving in, et cetera, et cetera. And I think what's really clear is you have to have a discussion on purpose and values. Daniel Pink wrote that famous book, Drive. What motivates us? Mastery, autonomy, purpose. So the question for people is like, what is your purpose in the job? And what are your values? And let me tell you, by asking people their values, I find that their values aren't what I expected them to be. And they don't always align with mine, but they can still align with the team.
Yep. Yeah.
So you learn a lot. So if that's the case, if you as Dr. So-and-so value such and such, then we want to do what we can to make sure we protect that to the fullest extent possible. While you still have to do the other stuff, like give a couple lectures here and there, and you got to do your annual training, which everyone hates online. There's nothing I can do about it, but you got to do it, et cetera, et cetera. Our job is to keep you engaged in the things that are most important.
No, that is a very productive outlook on how to assimilate different stories together to form that team. So when you first introduced, or not introduced, when you first developed as a group this motivational, this ethos, this statement that really created the rules of VCU or VCUID, how did that impact your team? Did you see a difference in their motivation? Did you see a difference in behaviors at all? Or was it more of a subtle change over time? Or is it still yet to be determined?
It's subtle. I will say my group is like 98% team players at all, 99% team players at all time. Seriously, it's very uncommon that someone doesn't want to collaborate. And even before that, before we made the ethos statement, we're a closely knit group such that if something happened to one of us, essentially happens to all of us. So we were responsive in that way, but it was important to codify. And I think that the real impetus was that. So we're getting all these reports from the health system. Oh, physician burnout is an all-time high, et cetera, et cetera. And when I looked at that and I discussed it with those close to me here, it really dawned on me that if we wait for the health system, the university, to really do something, we may be waiting a long time. So we should take care of ourselves. And the first step in taking care of ourselves is recognizing there could be a problem and having a team culture that's supportive and a dynamic that leads to growth. That's the first step. The second is defining your values, protecting the work that goes with your values, et cetera, et cetera.
Well, and you mentioned earlier that there's certain tactics that can help mitigate and prevent burnout before it even happens that you've been focusing on or ruminating on. Can you share some of those with us?
Yeah, so years back, maybe about 6 or 7 years ago, there was a paper published, I think it was 17. I think it was by Kate Shanafeldt and group, who are like the gurus in preventing or studying burnout and wellness, et cetera, that showed in academic medicine that doctors who were able to spend 20% of their time on things that are most valuable to them were significantly at low risk of burnout. I read that. I also read the book, The 80-20 Rule, the Pareto Principle, which blew my mind. I'm like, so really 80% of your outputs are from 20% of your effort. So you got to find out what's important and make sure you do that 20% of the time. Someone's onto something here, and it's not me, but I'm going to rob these ideas because they're good. So the idea is to make sure that every team member can say, what is most important to you?
Mhm.
Can we do to protect that to the maximum while still falling in line with your contract and what else is necessary for
Yep.
the
Of course.
division? That's a big driver of prevention of burnout. It allows people to feel valued. And if you let them do what they want to do, they feel they have some autonomy, they have some purpose. So it
Yep.
kind of aligns with Daniel Pink's Thrive. But you got to start with why. Like, why are we doing this? And you have to define the why you want to do what you're doing. The more I talk with people across the division, it's amazing what you get back as to what's most valuable. So I'll give you an example. We have one of our assistants here, administrative assistants. They're all great. One of them, I asked her, what's most valuable to you in your job? And her response was, I really like coordinating the patient clinic visits.
Hmm.
Now, generally, most people don't like doing that. They're like, I don't like calling for labs, getting them faxed, et cetera, getting stuff from the primary care, from the external ones, not the ones
Of
outside of
course.
PCU health
Of
system.
course.
I'm like, that is a person, like, if that's what she likes, we celebrate that.
You're like, we've got work for you.
Yeah, we got work for you, we celebrate that. If that's what you really like, I mean, that is amazing. You know, another assistant we have here loves preparing, like preparing all the things that are necessary to travel to conferences, et cetera. So
Mhm.
to do that, but that means that's of importance to someone. So I don't
Mhm.
minimize it, but those are the ones you put them in those positions or give them those tasks that they like, and you keep them
Yeah.
engaged that way. That's what I'm saying.
Yeah, finding where the need aligns with what people really love and value. And what's striking me as you're talking about all of this is, I mean, you're the head of a division. You're clearly busy. It's not like you're sitting here on Facebook all day, but you're prioritizing and taking the time. This is something I also noticed of my division chair when I was a fellow too. Taking the time to make sure to get to know every single person, not just the people in the top roles, but every single person in the department, so you can really harness who they are as a person.
Correct, and not only get to know them professionally and somewhat personally, learn about their families and what's
Mhm.
important to them, but also make sure that they're aware of what they're doing is still very valuable. Even if it's not being emphasized
Mhm.
at this time, it's still critically important. In fact,
Mhm.
going back to a sporting analogy, in in the paper I published on soccer and leadership, I
Uh-huh.
used a quote from Vicente del Bosque, which is the famed Spanish manager who won the World Cup, and he was the manager of
Mhm.
the coach of Real Madrid. And he had a very cool philosophy that I read in a book. He said, on a match day, only 11 to 15 men will play for
Mhm.
players in the field, and there's like a roster of 20 something. So his job the day after a big match, when there's training, is to spend time with all the players that didn't play. He focuses on them to keep them motivated, let them know how valuable they still are. I need you for this next match. I'm going to need you 30 minutes next week for this. So everyone feels they're doing something important. And that's the goal. It's not a perfect analogy because there's no matches in what we do,
Of
but
course.
you certainly want to know what makes people tick, so to speak, uh, connect with that with regularity such that they don't feel that you've undervalued.
No, I love that analogy. That's a really great parallel to draw, not just in medicine, but honestly in so many different aspects of leadership in life. And as we know, infectious disease people end up doing anything and everything under the sun. So it's a technique that can really be applied ubiquitously.
Yeah, you're talking about everything under the sun. That's another thing is we want to keep people focused. So if you've told me that three things are important to you, the why you're doing 4, 5, and 6, they're low value and uncompensated. Don't do that. Like,
Yeah.
stop that right now. It's like, get that off your plate.
So how do you have that conversation with people to say, okay, this is high value, this is low value. What can we rearrange? How do you approach that conversation?
Yeah, so you have to be careful when you talk about values because we may have different values, right? But if we're all on an academic infectious disease team,
Mhm.
I can at least give a perspective as what is valuable from the university's perspective on promotion and tenure and faculty development. I can give you that. Okay. So, and then we have a contract. So if someone's 80% clinical, you got to do somewhat 80% clinical work, but that other 20% that we're giving you to do other things, make sure you define what's most valuable for you there. And don't at any time let things encroach on that 20% that's not of value to you. And value could be value with compensation or value with no compensation.
Mhm.
For example, if someone is interested in some element of medical education and wants to do, I don't know, interviews with for medical school entrances, and that's
Mhm.
considered valuable to them because they're on an education path and they want to do that for a couple of years, then I will support that, understanding that's not much compensation.
Mhm.
That's valuable. What would be other valuable uncompensated work? Well, if you're on a clinician educator track, publishing 1 or 2 manuscripts a year, that's high value, no compensation. But if you're going to move
Mhm.
on from assistant to associate professor, you need those 1 to 3 manuscripts a year to make that academic and or
Yeah.
the research kind of academic grade that you need. So those are things you have to negotiate and give guidance. We do that through formal mentoring sessions with everyone. But an important thing also, I think, uh, Megan, is just to have the door open. And
Mhm.
people know that if I'm here, the door's open, I'm available. Come chat with me anytime you have a question. So,
That's awesome. That's a key underlying policy that I think is very, very transparent in everything that you've shared, is that you are very approachable and that everybody feels comfortable doing so, which is important.
we try. I worked with Priya Nori from Albert Einstein College of Medicine, and
Uh-huh.
we published a paper on minimizing low value uncompensated work. That was in
Mhm.
CMP in February. And it's a 6-step program, but the last program is if you're still tempted to do low value uncompensated work, go to your mentor or your sponsor. That should be your division chair or something, so we can at least guide you through it or maybe you out of it. Do that so you can stay focused.
No, that makes complete sense. I saw that paper actually. Somebody, a previous guest had shared it with us, so it was really fascinating to see kind of that step. And we're talking a lot about the tenor that you set in the team environment and trying to help everybody thrive on their own. How about people who are not quite leadership yet? How do you enable them to manage up?
Oh, great question. So I think the important thing the message to pass on to the team is that everyone can lead. It's not a title. I mean, it is a title
Mhm.
at times, but you can show leadership if you're interested in a small project. Even if it's a one-off project, you can be of value. You can be a
Mhm.
leader by being collaborating in a project and taking that project a couple steps forward. So we give everyone encourage opportunities to lead. I also think it's important for those that are clearly on leadership paths or who are maybe the healthcare epidemiologist, maybe the OPAT team director, et cetera, or the stewardship director, to say, hey, you are, believe it or not, you're actually leading a team. It's a team within a team, but you're an important member of that leadership team. I would like to offer you leadership training, and there's training internally at VCU, which is obviously the cost is right for us because it's internal. We have those opportunities, and there's mentors we can get through talent development at the university, give them the coach and mentor to help them. And then we try to send as many people as possible to courses like the IDSA Leadership Academy. It's
Mm.
only one a year, of course, but those are important, I think, leadership opportunities and educational opportunities.
They are, and it's great that you sponsor them because it's cost prohibitive to some people, especially in academic medicine.
Well, you have to make the argument to the department chair and to the university, like, look, we have to have a leadership structure. I mean, if I
Mhm.
get hit by a bus tomorrow, there's got to be someone who can step in right away. We have to
Mhm.
have a parent; she's ready to go soon as soon as she's called to action. It also, and I think this is really important. I'm not sure how to measure the impact of this, but when I take a vacation, I truly just check out, and I will tell the whole team, I'm like, I'm leaving. Dr. Julie Rezicek, associate professor, she's in charge. She's the associate chair. I
Mhm.
trust her with all decisions. That's the standard message.
That's really great. I mean, I have to say, growing up in medicine, residency, fellowship, all of my friends in different genres of medicine, we all talk about how vacation time means it's time to do the research you didn't have time to do when you were on the wards.
You got to vacate. Vacation is vacate.
And that's so key. Honestly, that is a big part of burnout and a big part of why many of my colleagues who left academic medicine left is because they felt like they never got that break that they badly needed. And private practice gave them opportunity to get those breaks and actually have vacations.
Right.
So that is, I love the fact that you're fostering that thought process.
But we're trying. That's for sure. We're trying.
And so, in the midst of all of this, I mean, one of the big things that stuck out to me with your motivational statement, the rule of the department, is inclusivity. So I imagine that that really helps to create a diverse environment. But how do you personally help to bring in diversity into this world of medicine that traditionally has not been as diverse?
It's sad to say there's not much diversity that I've seen in the applicants. And what's really sad, and I was just reflecting on this the other day, is that if you look at Black or African Americans coming through our training program, been here 21 years, I think we've had two women and one man who are Black in the ID training program. And I look at, and when I think about the applicants, there are virtually no Black applicants. And in all the faculty that I've hired, and I've hired a lot in the last 11 years, I've not received one Black candidate, which is really disappointing. So what we do is, and I'm going to talk about infectious disease here, is what we want to do is, you've heard this too, that infectious disease is maybe a specialty in decline. You've heard that, right? I mean, I'm not sure I entirely believe it, but I've heard a lot of it, and I've even heard it at national meetings. So we have to set up the mindset here that if anyone is interested in infectious disease, i.e.,
Mhm.
a college student, even a high school student, let them go through the appropriate channels to register with the hospital volunteer office, et cetera, and they can come spend time with us on programs in in projects and in clinics. So make it a very welcoming environment to all learners, and that usually attracts more interest in the specialty. We've been doing that for years, and I get a fair number of messages now coming from mostly college students from the VCU looking for opportunities in infectious disease. And you got to keep an open door policy. And I realize that there are a lot of structural barriers and racism, et cetera, but I try to focus on what we can do
Mhm.
at this level. And I think what we can do is to be as open, accepting, inclusive, and really, really be good role models for others so that people see our enthusiasm. And if
Mhm.
we show enthusiasm, it should rub off on others and maybe be infectious in a certain way. It's really
That's that's great. And I'm from Iowa, so I'm very corny, so I love every pun you can throw at me.
important.
Um, how do you propose? I mean, you brought up this quagmire that's a larger than just VCU or larger than a single system issue. If we're not having the applicants, and it's great that you're trying to foster at a young age there, what are some systemic things we can do, or the IDSA or the larger community should start thinking about doing as far as trying to build up this more diverse workforce?
Well, if you're really going to go, I guess upstream, I guess as upstream as our go will be to the medical school level. I mean, you can go
Mhm.
to the high school, kindergarten, grade schools, et cetera, but I don't
Yeah,
have, I'm not an educator at that level. I don't really know the best
of course,
policy.
of course.
I think for IDSA that we should be very, very aggressive in encouraging medical students, interns, residents, and fellows to attend conferences, have special programs for them,
Mhm.
reach out to them. I mean, I think that any U.S. medical student who wants to attend IDSA should be a registration of, like, if not free, $25. It's
Mhm.
super cheap, and with some grants and or travel allowances so that they can come and see what it is to be an infectious disease specialist. As you know, you go to IDSA or SHE or one of those conferences. Rarely do you go there not inspired.
Yeah,
Those are inspirational touch points, right? You go there and you get
sure.
inspired. So the more people that we can attract to that and inspire them, the more they will, align themselves with their home institution ID program, medicine programs, and hopefully seek opportunities for this as a professional career.
No, that's a great idea because the only programs you can really go to as a med student, let's be honest, are the ones where you've already done some type of research project, and so that's why you're able to go present, and that's why you're funded. But just to explore it as a career choice, that's
Yeah.
a whole different dynamic that would be so critical. I love that thought.
And now we actually have, like, college kids that come to me now. They're like, I'm in third year of college and I've taken public health and statistics. I'm like, whoa, I didn't even know what that even meant. When I was in college, I had no idea, zero understanding. This is like late 80s, early 90s. And now the college students are coming to you so much more sophisticated than I was at that age. We should be recruiting them to come to our
Mhm.
professional society meetings to learn more
Mhm.
about the profession, not just medicine, but also.
Yeah, I mean, and there's so many facets of the infectious world that not all of it has to go through medical school. You're exactly right. No, this has been really wonderful and very, very energizing to hear how things are going and how you're structuring this inclusive environment at VCU.
We're
If you
trying.
were to no,
Trying.
this is really awesome. This has been a fun conversation. If you were to leave our audience with one last tidbit, what is the thing that you want to leave them with today?
Okay, so I would say in whatever you're doing in your professional work, I guess in all facets of life, you really start with why. Be very clear on your purpose and what your values are. Be very clear on that and make sure you meditate on that as you work with your colleagues and work with your divisions. And one thing we didn't touch on, but I think is really important, is you have to be aware of the importance of perseverance and grit,
Mhm.
because you're always going to have a setback. The career is never going up steady, always. It's always a couple steps up, one notch down, a couple steps up, two notches down, three steps up, a notch
Yep.
down, et cetera, et cetera. So you have to really know or be aware of setbacks. They're coming, they are inevitable. And those who really, really succeed know how to persevere and are gritty. But to be gritty, you really have to know what your purpose and values are, what's important.
Mhm. No, I love that. That's a great parting message. Thank you so much for joining us, and I hope you have a wonderful day. I look forward to seeing all the good work you continue to do at VCU.
Oh, you're too kind. Thank you so much. It's been a huge pleasure. A lot of fun.
Stories of Care is a publication of the AMA and CDC's Project First Line. Project First Line is a national infection control training collaborative working to provide all healthcare professionals with the foundational infection control knowledge they need and deserve to protect themselves, their patients, their coworkers, and their communities. For more information, trainings, and other infection control resources, visit cdc.gov/projectfirstline and amafirstline.org.